Check. Hello. Good evening, friends. Yeah. So I think you are attending the live sessions of INI SS SG recalls. This is the fourth day of the recall of May 2025. Previous year recalls are available in the app. Please go through the app. So today we will discuss esophagus and pancreas questions. So please understand, in INI SS, you will have 50 marks from gastro core, gastro topics. 30 marks will be from general surgery, which includes GAT based on Bayesian law. So there may be some questions from Bayesian law, GAT will also be there. So 20 marks will be from Viva question, which is done separately at the end of 80 marks. Those who are selected for the interview will be given this 20 marks. This is a plan of INI SS. So you will be joining JIPMER and other institutes with only this 80 marks. Those who want to join into AIMS will be having an additional 20 marks in the interview. This is a basic protocol of any exam, any INI SS exam, let it be gastro or neuro, whatever it is. So let us now start with the questions. See, some questions may look very easy. Probably they are belonging to general surgery GAT questions. Some questions may look very difficult. They are the actual gastro core questions. So we have discussed around 60 questions in this entire 4-day session. So probably it included some questions of GAT and HPP. We don't know, but these are the questions. Achalasia in a 70 years old with a long history of reflux. What is the next step? These are all very easy questions. A patient who is having a long history of reflux is probably, we should think of cancer development. So therefore, long-standing achalasia, there are chances to have malignancy, and hence endoscopy is done to take biopsy. And especially this is a very old age, 70 years plus, say maybe a case of pseudo-achalasia also. So better we have to go for endoscopy and biopsy. So simple, straightforward question. See, I request you, please go through Shackelford, all the barium images. In page number 53, this image is taken from. All the images of barium will be asked. Every year we are seeing one question of barium image from this section. Therefore, please go through this section, this page, and this is a classical question of lower esophageal stricture. You can see the classical lower esophageal stricture image from Shackelford is directly asked. Strictures are identified as segments of luminal narrowing or non-distensibility on esophagograms. Short stricture, okay, please remember short strictures, short segment strictures can be seen in peptic ulcer, peptic stricture, Barrett's, or on medicine, pill-induced esophagitis. Pill esophagitis, peptic strictures, Barrett's strictures will be having short segment strictures. So they have short segment strictures and nodular inner margins, and shouldering effect is a feature of malignancy. Long segment strictures can be seen in post-radiotherapy or caustic ingestion, corrosive ingestion, or long-term nasogastric tube placement. So these are the causes of long-term. So this question can come from this paragraph. So short segment stricture, shouldering effect, long segment stricture. So please don't forget, long segment strictures are radiotherapy induced or corrosive induced. So this is a lower segment stricture you are seeing here, lower esophageal stricture, probably due to corrosive, whatever it may be, but it's a stricture in the lower end of esophagus. Okay. So eosinophilic esophagitis is sometimes considered a long segment stricture. However, some authors describe it as small caliber esophagus. So small caliber esophagus is a feature of eosinophilic esophagitis. Multiple strictures are uncommon but can be seen in graft versus host disease. So there will be super specialty SG level questions will be like this. So multiple strictures are common in which condition? Graft versus host disease, epidermolysis bullosa, Pempe joint, and caustic ingestion. You get multiple strictures. So this is a classical stricture based question. So please don't forget, images of barium swallow will be asked. Please go through images of barium swallow from Shackelford. I know very well it is very difficult to read Shackelford during the INI SS preparation, but some topics which are being repeatedly asked, you have to go through those topics alone as at least the images. And this image is repeated at least 3 or 4 times in Shackelford. So this is a picture showing you you can see here we are cutting the stomach like this. And so this picture shows a reversed gastric conduit based on which artery? This is based on a left gastroepibloic artery. Please remember it is based on left gastroepibloic artery. So based on left gastroepibloic artery, we bring the conduit to the esophagus. This is usually done for corrosive injury, esophageal replacement in children with corrosive injury. It is mainly done for benign disease, not for malignant disease. This major advantage of this reverse conduit is the reservoir function of stomach is maintained. So those who are preparing for the regular exams, you'll know very well. The commonly used conduit is we cut out and remove this part and we bring this esophagus based on right gastroepibloic artery. This is what we commonly use. But in this case, we use left gastroepibloic artery mainly for a benign disease. So here you should be very careful. You should bring it to the top, especially used in benign conditions. So typically, the right gastroepibloic artery is divided about 4 centimeter proximal to the pylorus. We have to divide it 4 centimeter proximal to the pylorus. In case you need a longer length of stomach, we can do a small modification. What is that modification? We can include this pylorus also and we can cut it here. We can include the pylorus also and we can cut it here. That is called as extended reverse conduit. That's an extended reverse conduit. So there in this case, the right gastroepibloic artery is cut at the level of origin of GDA. At the level of origin of GDA, you cut it and we take it as such, including duodenum as well as some part of pylorus, we take it up. This is a definite question for many SG exams. So especially INI SS, this is repeated at least 3 or 4 times in the past 5 years. So reverse gastric conduit. And one important thing I will tell you. So if you are going to do all the repeat questions of the past 3 years, we have already passed 3 years, we have put all the repeat questions in our app, especially surgical gastropod. Please go through those question banks. At least you go through those questions, you will definitely get at least 50% of the questions. 50% of the questions will be repeat only. And this is again a repeat question. At least the repeat concepts will be there. They may not be asking repeat question, but they'll ask the same area questions. So this is a question on reverse gastric conduit. Okay. So reverse gastric conduit, please go through that. POEM is done for. POEM is a peroral endoscopic myotomy is done for large hiatus hernia with achalasia is a one important contraindication. So whenever there is an hiatus hernia, we will not do POEM. That is an important absolute contraindication. Okay. So please don't forget that's an important absolute contraindication. And where all we can do POEM? POEM can be done in previous surgical myotomy, previous Botox or previous POEM. Direct line from Shackelford. There are no absolute contraindications to POEM other than the inability to tolerate general anesthesia. Patients with the end stage sigmoid achalasia or those with prior intervention are no longer considered to be relative contraindications. So previously sigmoid achalasia was a contraindication. Now it is not so. Patients have been successfully undergone POEM after dilatation, Botox or prior POEM and even after myotomy. So let it be dilatation, let it be Botox, let it be POEM, let it be myotomy. I can again do it. So hiatal hernia are considered to be contraindicated for POEM due to high risk of GRD postoperatively. So laparoscopic Heller's cardiomyotomy with the hernia repair and partial posterior fundoplication is preferred for those who are having hiatus hernia. So hiatus hernia with achalasia, we should not do POEM. And patients who cannot tolerate general anesthesia, we will not do POEM. Otherwise, we can do POEM for all the other patients. This is a direct question, multiple choice question. So go for B, C, D is correct. So always there will be a question on caustic injury. Though it is not much discussed in Shackelford or Sabiston, it is much better discussed in Bailey and Lowe compared to these books. Always there will be a question on corrosive injury. So corrosive injury is divided into 2 phases. One is acute necrotic phase. So acute necrotic phase is a phase characterized by cell necrosis, lasts for only 3 days. Necrotic phase. Second phase is mucosal sloughing with ulceration. Ulceration phase, necrotic phase, ulceration phase. So phase 1 is necrotic phase. The tissues get necrosis. Second is ulcerative phase. So ulcerative phase, so this is only for 1 to 3 days and ulcerative phase is for 4 to 12 days. Okay, 4 to 12 days. So during this 4 to 12 days, the esophagus is at weakest point. This is the weakest point. So corrosive injuries, sometimes they will do gastric conduit if the gastric mucosa is not damaged, but as a PG entrance MCQ, corrosive cases, we will not use gastric conduit, but they are mentioning it for benign cases, not for corrosive usually, but for benign cases. I'm telling you, don't worry about the exact questions. We don't have the exact questions or exact answers, but I am just discussing the concepts which are asked in the exam. So here you should carry home the concepts, which are all the questions asked. You go through those topics alone from Shackelford or Sabiston thoroughly. That is the point. So there may not be minute changes may be there in the choices, but just remember necrotic phase and ulcerative phase. Necrotic phase 1 to 3 days, ulcerative phase 4 to 12 days. In this 4 to 12 days, increased risk of perforation. If you do endoscopy, you can perforate. Then comes the third phase, stricture formation happens, stricturous phase, which starts from 3 weeks to 3 to 6 months it can happen. So there are 3 phases. So stricturous phase, necrotic phase, ulcerative phase. So as the esophagus at its weakest point during the ulceration and granulation phase, invasive diagnostic procedures are better avoided in this place. Like dilatation, stenting, everything should be avoided. Acidic substances with the pH of less than 2 will cause coagulative necrosis. Eschar formation with acidic solution is thought to limit the depth of contact and therefore less severe injury in the esophagus. So acid causes less severe injury in the esophagus. Examination of esophageal tissue initially after caustic injection is notable for necrosis with the edema, hemorrhage and eosinophilic infiltration. So injury is further worsened by blood vessel thrombus, venous congestion. All these are happening in the acute phase. Fibroblasts are abundant in 4 to 7 days after injury, resulting in deposition of fibrin and formation of granulation tissue. Esophagus remains fragile and prone to perforation up to 14 days. Scar formation and stricture can present as soon as 3 weeks after injection. So the question point here is, between 4 to 12 days, what all happens? Key pathological features are mucosal sloughing, ulceration, granulation tissue and fibroblast activity, inflammation and bacterial invasion. Therefore, we start giving antibiotics. Tissue weakness, vascular thrombus. These are all seen in the 4 to 12 days ulcerative phase. So what is not seen from the question? So ulcerative phase of caustic injury does not include all except sloughing is seen, granulation tissue is seen, bacteria invaded seen. Excess collagenous deposition is not seen in ulcerative phase. That's a question which from the choice, I think the choice which was given was not having excess collagenous deposition is except. So except excess collagenous deposition is the answer for this question. Ulcerative phase includes sloughing, granulation, bacterial colonization, everything from internet sources. This is from internet sources. In Shackelford, this question was not there. So I just took from internet sources. From the internet sources, probably there is no collagen formation. Collagen formation is not seen. So this question is again another simple question from Sabiston. Esophageal perforation 24 hours without necrosis. The patient has no necrosis. Pleural effusion of 100 ml, turbid on drainage. Only mild tachycardia, otherwise patient is stable. What will you do? So here is a very classical question. Ideal time of repair is within 24 hours. So if the patient comes to you within 24 hours, you'll do a single layer repair. Single layer repair we can cover with a flap. So more than 24 hours also, if the tissue is healthy without necrosis, I can do single layer repair. If the tissue is unhealthy, then only we go for a T-tube drainage or other things. Let us see. So in stable patients, repairs can be buttressed by a flap of healthy tissue, that it be intercostal muscle, pleura or strap muscles if necessary. In delayed presentation, another option is repair over a T-tube to create a controlled esophagocutaneous fistula, which diverts the flow and helps control sepsis. In extensive injuries not amenable to repair or with known underlying pathology, which would require resection, primary esophagectomy should be considered. with an underlying pathology like a achalasia or a cancer, we should try to go for resection also. In these cases, reconstruction should be deferred and a cervical esophagostomy is created. Okay, we will temporarily create a cervical esophagostomy. Another option is esophageal exclusion and diversion. This is done by creating a cervical esophagostomy and stapled division of esophagus distal to the injury. So we will staple and cut the esophagus and let it remain inside. We will decide it later. So this is another option. So when the tissue is healthy, we will go for a single layer repair. So in this question, it is healthy, so I will go for a single layer repair with a flap. If it is due to achalasia going for perforation or cancer going for perforation, I would have done esophagectomy also. Okay. So this is again a repeat question. Please remember, this is again, I told you, there are so many times the questions repeat. This is a transhiatal esophagectomy was performed. You should understand in esophagus, for example, this is a esophagus. The blood vessels will form a leash of small vessels before entering the esophagus. This is a main vessel. This is a main vessel that will divide into small vessels and enter into the esophagus. This is one of the reasons when you do esophagectomy by transhiatal method like this, these smaller vessels will go for occlusion and will not bleed much. They will go for bleeding will stop by doing a pack after removing the esophagus. That means what are the major vessels which are bleeding? Number one, bronchial artery. Bronchial artery, branches of bronchial artery is supplying the middle of the esophagus. Aorta giving direct branches and bronchial artery giving direct branches supplies mid esophagus. Lower esophagus from left inferior phrenic artery. Left inferior phrenic artery supplies lower end of esophagus. Inferior thyroid artery supplies upper end of esophagus. Upper end of esophagus, inferior thyroid artery. Okay, inferior thyroid artery supplies. Single layer is what mentioned in book. So therefore, there is no need of doing double layer with flap. Single layer is enough. There is no separate, nothing wrong in doing double layer, but single layer is enough for esophagus. Usually in surgeries also, we don't do double layer in esophagus. So naturally, we do single layer only. So inferior thyroid artery, inferior phrenic artery, and these arteries. So these are the arteries: inferior phrenic artery, inferior artery, and what are the other arteries? Please remember, arterial supply originates from bronchial arteries, and majority of the patients have one right-sided branch and one or two left-sided branches of bronchial artery. There are usually two esophageal branches from the descending aorta. Esophageal branches from the descending aorta. There is a vast network of collaterals within the esophagus, allowing esophagus to receive blood supply from larger vessels. Because of this rich intramural network of small vessels, esophagus can be completely mobilized from esophagus to aortic arch, yet continue to be well perfused. So the arterial branches of the esophagus will be a fine small vessels, and bleeding can be controlled by packing the mediastinum. Please don't forget, by packing the mediastinum. This is a picture from Shackelford. You can see how minute the vessels are. Say esophagus primary repair of a perforation, single layer or double layer is not a contraindication for a single layer or double layer. But I will say usually what we practically do is single layer. Is it mentioned in Shackelford somewhere? Because in this paragraph in Shackelford, I couldn't see whether there is a single layer or double layer. If anything mentioned in new edition Shackelford, we'll go for a double layer. Okay. I don't think there is a separate point mentioned in Shackelford, which I was going through page number 417. So repairs are buttress, but if there is a double layer mentioned, nothing wrong, you can go for double layer. So please verify the material from the book. Okay. So this answers are cervical esophagus by inferior thyroid artery, thoracic esophagus by descending thoracic aorta and bronchial arteries, abdominal esophagus by left gastric artery and left phrenic artery, left inferior phrenic artery. These are the arteries of esophagus. So esophageal supply. Okay, don't forget these points. So these are the 7 questions came from esophagus in this exam. 7 questions of this, 3 or 4 questions may look like general surgery questions, but I'm not sure whether it's from general surgery or from Shackelford, but yeah. Okay, we will verify the page number and I will say you, because in What we do practically, I have mentioned here, single layer. Maybe from page number 417 of your book might be giving a clear idea, because this injuries of esophagus is a very important topic. Please go through that injuries. Let me show you. See the new edition Shackelford. Let's see from the new edition Shackelford. New edition Shackelford is an extraordinary book compared to old edition. It has made much better editing. There is no unwanted stories on studies and all are not given in this book. Because in page number 417, primary repair is a gold standard, especially in patients who present within 24 hours. Depending upon the location, etc., they have mentioned. In stable patients, repairs can be buttressed by a flap of healthy tissue. Like that they have mentioned. The key steps in successful repair are debridement of non-viable tissue, extending the myotomy to the opposite to expose. That is for, they are mentioning it for expose the extent of mucosal injury, a multi-layered repair, a wide range, wider drainage. So they are mentioning multi-layered repair. So you can go for double layer repair here in this on this question, because there is a line from Shackelford in page number as 417. There is a line mentioning in extensive injuries, you can go for multi-layer repair. Multi-layer repair is mentioned. They did not mention double layer, but they are mentioned as multi-layer repair. You can therefore follow that line. So the key steps in successful repair are debridement of non-viable tissue, extending the myotomy to expose the extent of mucosal injury, multi-layered repair, and a wider drainage. But this point is given related to achalasia going for perforation, but we have to confirm it from other editions. So, but in Sebastian, many times I'll tell you now, even most of the notes of Shackelford is Sebastian. So if it is mentioning in Sebastian as 2 layers, you can go with 2 layer itself. That will be better. 2 layer will be better. Okay. So go for B. 63-year-old man with a microcystic neoplasm in the head of pancreas shows central scar. Central scar in a cystic neoplasm. Hyperintense tumor with a central scar, CEA, CA19 normal, alkaline phosphatase elevated. So this is a classical case of serous cystic neoplasm. Serous cystic neoplasms, the image shown here is an MRI with a central scar. You can see the MRI with a central scar. So you all know very well serous cystic neoplasm, mucinous cystic neoplasm, IPM1. In serous cystic neoplasm, amylase, CEA, both are normal. In mucinous neoplasm, CEA elevated, amylase normal. In IPM1, amylase and CEA both are elevated. This is on fluid analysis. EUS guided fluid analysis. In serous cystic neoplasm, there will be sunburst-like calcification on CT. In mucinous neoplasm, you get eggshell calcification. In IPM1, you get dilated pancreatic duct filled with mucin. On a CT scan, these are all CT scan findings. Sunburst calcification in serous cystic, eggshell in mucinous, dilated pancreatic duct in IPM1. In IPM1, there will be fish mouth ampulla on side viewing scopy. Fish mouth ampulla will be seen on side viewing scopy. Okay, don't forget this basic question. This is a straightforward question on serous cystic neoplasm. BISAP does not include bedside index of severe acute pancreatitis. The bedside index of severe acute pancreatitis, directly you can pick up the answer. Amylase will not be used in scoring. So what is BISAP score includes? There are many scores. Apache 2, BISAP of more than 3, Apache 2 of more than 8, modified Glasgow score of more than 3, Ranson more than 3, urea at admission more than 60, C-reactive protein of more than 150 units per liter. All these are scoring systems in pancreatitis. Here, you should not forget BISAP score. The mnemonic itself is BISAP only. Blood urea nitrogen, B. Impaired mental status, SIRS, age, pleural effusion. This is what included. So blood urea nitrogen, impaired mental status, SIRS, age and pleural effusion. This is called as BISAP. This is called as BISAP scoring. Okay. So please remember BISAP scoring, GCS is included as impaired mental status. Sequence of RAMS. Again, this is a repeat MCQ. RAMS will be always a repeat question in any exam. So this video, in our discussion video in INI SS also, we have discussed everything about RAMS. So in RAMS, what is done? Please remember the order. So RAMS is radical antegrade modular pancreaticosplenectomy. So this is conventionally what we do. We come from this place, come like this, and wherever you want to cut, for example, there's a tumor here, you will cut like this. This is radical antegrade modular pancreaticosplenectomy. This is normal conventional splenectomy. In modular pancreaticosplenectomy, we cut it first here, then we go like this. That is radical antegrade modular splenectomy. What all things done? So step 1, open the lesser sac. Okay, step 1, open the lesser sac. So gastrocolonic ligament was divided to enter the lesser sac. Mobilization of pancreas began at the inferior border to visualize superior mesenteric vein, splenomesenteric confluence, and portal vein. So mobilization of pancreas was performed at the superior border. So inferior border, superior border. So along with that, lymph nodes of common hepatic artery and GDA were dissected. So this is RAMS is usually done for cancers. So they remove the nodes of common hepatic artery and GDA. Then you create a tunnel behind the neck of pancreas, and now pancreas neck transected. This is the first step. First invasive step is we cut the neck of pancreas and dissect the nodes around the celiac artery. Then that second step only, splenic artery and splenic vein are ligated. So naturally, always we ligate the splenic artery followed by splenic vein. So pancreas mobilization, neck division, splenic artery ligation, splenic vein ligation. This is the order. So lymph nodes anterior to the aorta between celiac artery and SMA, and those anterior and to the left of SMA are dissected. All the nodes of superior mesenteric artery dissected. Distal pancreas was dissected to the soft tissue of retroperitoneum. Either the anterior or posterior rams. There are two types of rams, anterior rams or posterior rams. What is it? It is purely based on adrenal gland dissection. So when you are doing dissection, proceeds in front of adrenal gland is anterior rams. Behind adrenal gland is posterior rams. This is done for tumor infiltrating the adrenal gland. So posterior rams is an extensive surgery done for tumor infiltrating adrenal gland or Gerota's fascia. So otherwise, usually we do only anterior rams. That is commonly done. So posterior rams includes adrenal gland, and some part of Gerota's fascia is also included in posterior rams. Okay, rams is a common MCQ. So radical antegrade modular pancreatosplenectomy. So similar to rams, there will be also another question always, modified Appleby procedure. So modified Appleby procedure and rams procedure are two topics related to pancreatic tumor. So please go through modified Appleby procedure. Please go through modified Appleby procedure. So modified Appleby procedure is a procedure in which celiac artery is resected. Celiac artery will be resected. That is very important. Please go through about this procedure. This can be asked again for your exam. Celiac artery resected for a pancreatic CA in the body. Pancreatic cancer in body infiltrating celiac artery will be resected. That is very important. Okay, that is modified Appleby procedure. Best localization of insulinoma. Probably this is a general surgery question. Best localization of insulinoma is by EUS. So I took from Shackelford the various points. If a biochemical analysis of insulinoma is made, but no pancreatic lesion can be identified despite CT imaging or MRI or EUS, specialized invasive procedures are available. So I want you to understand invasive procedures. So somatostatin based PET CT is of limited use. Somatostatin scintigraphy is of limited use in insulinoma because insulinoma does not have somatostatin receptor. The only neuroendocrine tumor without somatostatin receptor is insulinoma. Therefore, what we can do? We can selectively cannulate. Arterial cannulation and calcium stimulation test is performed via arterial catheterization of splenic artery, SMA and GDA. Calcium is injected sequentially in those locations while a separate catheter measures insulin levels at hepatic veins. Because intravenous calcium will stimulate secretion from insulinomas, not from normal islet cells. An increase of 2 to 3-fold of insulin level in the hepatic vein indicates there is a insulinoma in the injected territory, maybe along the splenic artery territory or along the SMA territory or GDA territory. Surgical exploration has traditionally been used. So that is nothing but intraoperative assessment was traditionally used. Those who are unable to find out where is insulinoma, they open and they will palpate and find out. So this is no more advised. Okay, this is no more advised. It is not recommended anymore. Morbidity of exploration is considerable and remains that 10% of the tumors are not identified even after invasive surgery. Therefore, intraoperative assessment is no more mentioned. Intraoperative ultrasound, I thought there will be a line about it, but it is also not there. So SRS not useful. Bimanual palpation is also not useful. So EUS is one of the best localization methods as of now from Shackelford, but practically we can also do pancreatic mobilization, bimanual palpation, and intraoperative ultrasound also can be done, but it is mentioned in clearly it is not recommended anymore to do surgical exploration because 10% of the tumors are not identified even after invasive surgery from Shackelford. Okay, this is the line from Shackelford. There are 10 questions from pancreas. Pancreas had major questions. Majority of the questions in this session came, 10 questions came out of 50 questions, 10 questions came from pancreas. So 7 questions from esophagus and other questions are equally distributed like liver and biliary system. We had around 18 questions like that. So MRCP double duct sign. It's a repeat MCQ, PG level question, CA head of pancreas, direct line from Shackelford. Pancreatic tumors typically obstruct the common duct. Pancreatic head tumors typically obstruct the bile duct and main pancreatic duct, causing a double duct sign. Can you see? This is one duct, this is one duct, and this is one duct, double duct. This is pancreatic duct, this is bile duct, which are dilated, double duct sign. So this question also seems to be from Bailey and Lowe. Chronic pancreatitis best for early diagnosis. Once upon a time, the answer was ERCP and Cambridge criteria. Cambridge criteria was an answer from years back. Now it is EUS and Rosemont criteria. So please go through Rosemont criteria. Major criteria, major A, major B, all those things are we have discussed in our regular NEET SS classes also. Please go through that. Rosemont criteria is used for diagnosing early stages of chronic pancreatitis. So this is a very important update from Sabiston as well as from Shackelford. Clinical scenario of acute pancreatitis, which is not done. The most important thing, because right from our MS days, we were being told to treat aggressively. Aggressive fluid therapy is no more done. That is a very important update from new edition. There is no more aggressive fluid therapy. Prophylactic antibiotics are not given true. Ringer lactate preferred. Selective decontamination of intestinal tract. There is so many updates about this topic, acute pancreatitis in Bailey and Lowe. Let me tell you the important updates alone. The important first update is waterfall trial. So randomized patients to receive goal-directed aggressive or moderate fluid resuscitation. So goal-directed aggressive resuscitation versus moderate fluid resuscitation. In fact, what happened during the study itself, they stopped this trial. Because they found out those who are having aggressive fluid resuscitation became very sick. So therefore, what is the latest update? Ringer lactate with an infusion of 5 to 10 ml per kilogram per hour until resuscitation goals are reached, monitored by vital parameters and urine production. So change number 1, waterfall trial. So aggressive fluid, no more. Second point on infection prophylaxis in acute pancreatitis. In acute pancreatitis, early infections, especially bacteremia, and in the later phase, secondary infection of necrosis often have a significant impact. Therefore, they tried Propartria trial, compared outcomes after probiotics with a placebo with a severe pancreatitis. Probiotics were found to have no effect in reducing infectious complications. In fact, unexpected higher rate of bowel ischemia. Therefore, Propartria trial said don't use probiotics. Probiotics are no used. Aggressive fluid therapy no used. Most recent systemic review of randomized controlled trials have shown prophylactic administration of IV antibiotics does not prevent infection of necrotic tissue. So this is an old answer. This is a very old concept. Even with the pancreatic necrosis, doesn't need to give antibiotics. Antibiotics in acute pancreatitis are therefore given only for proven infection or infected necrosis. This is a very important point. And this is a new update, selective decontamination. What is this selective decontamination? We put a tube into the stomach and we pour the topical antibiotics into the stomach. that is called as selective decontamination. This is done with the clindamycin or drugs which acts on local action will be that. So this is very useful for many septic case, but studies with proper design adequate numbers are not available. So the use of selective decontamination should be weighed against the potential for an increase in antibiotic resistance and fungal colonization. So as of now, this is not so much used, but the effect of this acute and pancreatitis have been tested with the beneficial effects on morbidity, no impact on mortality. So this question can come. The next upcoming exam, selective decontamination has benefit on morbidity, but no impact on mortality question may come. Okay, don't forget this. And about the nutrition, there is a very important trial, Python trial. See, everything is a trial, Propartia trial, waterfall trial, Python trial. So in severe acute pancreatitis, we used to read not to give enteral nutrition. Now there is a line. Nutrition in predicted severe acute pancreatitis, head-to-head comparison of enteral nutrition through nasoenteric feeding and a parenteral nutrition showed that enteral nutrition was superior in terms of reducing organ failure, infected necrosis, and even mortality can be reduced even in severe acute pancreatitis. So please remember, the underlying mechanism for the beneficial effects could be reduced gut permeability and less bacterial overgrowth. Therefore, now they are advising in Python trial, severe pancreatitis were randomized to yearly nasoenteric feeding within 24 hours to the emergency department or to an oral diet initiated within the first few days of presentation with the tube feeding only provided if the oral feed was not tolerated after 72 hours. In fact, Python trial is versus oral feeding versus nasogastric feeding. They are mentioning oral feeding not tolerated, then only you put a tube. That's a very important update. So like that, there are so many important updates in this section. So endoscopically placed gastroenterostomy tubes are quite effective in early and mid-disease phases. These tubes permit gastric decompression and when patients manifest gastric ileus and deliver nutrition beyond ligament of treats. So those who are not able to tolerate nasoenteric feeding, we go for a nasojejunal feeding. That is a point from this line. Okay, this is very classical question. Don't forget, chronic pancreatitis non-invasive direct test. So what is this non-invasive direct test? Direct test of non-invasive is fecal elastase only. We are measuring the elastase, the enzyme produced from the pancreas in the motion. Therefore, it is a non-invasive direct test. So measurement of fecal elastase 1 is a preferred non-invasive study to diagnose pancreatic exocrine insufficiency. So fecal elastase of more than 200 is normal. Less than 100 is severe exocrine insufficiency. Similarly, we can also measure fecal fat. Fecal fat exceeds 7 gram, that is a steatorrhea. So what are the invasive direct tests then which are no more done? Number one, the test is directly we measure the pancreatic secretion by stimulus. So we will put a tube into the duodenum area and we stimulate the pancreatic secretion by a test meal as in Lund test. A pharmacological intravenous injection of a hormone such as secretin or CCK is injected. So duodenal intubation has to be performed with a triple lumen tube so that the gastric duodenal juices can be aspirated, and a non-absorbable marker such as polyethylene glycol is used to assess the completeness of aspiration. So it's a complicated test. You have to aspirate and test the enzymes. And similarly, the NBT PABA indirect measure of pancreatic function. This substance is administered orally and degraded in the gut by a pancreatic enzyme, and the breakdown product PABA is absorbed by the intestine and excreted in the urine. Its urinary level is measured. So one Lund test is duodenal intubation. PABA test is urine test. So these tests are cheap to perform but are non-specific, especially following a gastrectomy or in conditions that may alter the GI transit. They are rarely used nowadays. So invasive direct tests are no more used. We only use fecal elastase test. Don't forget this question, okay? So it's an easy question. Which vessel is not reconstructable in Whipple's operation? So this is a celiac artery. This is common hepatic artery. If there is a common hepatic artery infiltration, we can cut this part and we can do reconstruction connection like this. Superior mesenteric vein, portal vein can be resected and re-anastomosed, or we can put a graft. The only thing which is not used is superior mesenteric artery. So superior mesenteric artery comes under superior mesenteric artery involvement more than 180 degrees is said to be unresectable. Which is said to be unresectable means superior mesenteric artery which is involved more than 180 degree, we cannot cut and reconstruct. As on date, if it is superior mesenteric artery involvement, if the superior mesenteric artery involvement is less than 180 degree, we can do a sleeve resection and suturing also possible, but more than 180 degree, we cannot do anything. So less than 180 degree is borderline resectable. We will do borderline resectable. We give them chemotherapy and then we will decide. So that is borderline resectable. So the 10th question is on peanut syndromes. Peanut syndromes, pancreatic neuroendocrine tumor syndromes are multiple endocrine neoplasia MEN1, multiple endocrine neoplasia type 4 CDNK1B MEN1, CDKN1B. So von Hippel-Lindau, neurofibromatosis, tuberous sclerosis, all these patients can develop pancreatic neuroendocrine tumor. So von Hippel-Lindau, neurofibro, all the above. From the question, I think it's a multiple option question, all the above. So MEN1, MEN4, VHL, NF1, tuberous sclerosis. All these people can develop pancreatic neuroendocrine tumor. Direct table from Shackelford. Table is there as such in Shackelford. So necrotizing pancreatitis clinical scenario was asked. What they have, I'm not sure with the complete question, but I just filled up for completion's sake. The complete step is 11th question. This is step up approach, step down approach, bigger. So step up approach is the best. So what is the step up approach? Shackelford explains for pages about step up approach. So what we do, first we put a percutaneous drainage, pigtail catheter into the necrosis, and through that we will do a ward. Through the pigtail catheter pathway, we will go for a ward treatment. So video assisted retroperitoneal treatment, and through that ward completed, some patients may have some necrosis. We will do a minimally invasive pancreatic necrosectomy, minimally invasive procedures. The minimally invasive procedures can be endoscopically, we can do necrosectomy, or we can do laparoscopically also. That is the next step. And finally, we do open Beager's necrosectomy. This is order. This is called as step-up approach of Panther trial. This is called as Panther trial step-up approach. So don't forget Panther trial. So many trials have been explained in pancreatic necrosis, but everything is important. Pancreatic necrosis, I'll tell you some important topics from my section. Esophagus, be thorough with the achalasia. Achalasia, there will be a lot of questions in achalasia. And definitely there will be a question on corrosive ingestion. Corrosive, let it be corrosive directly or let it be images of the barium. So achalasia, corrosive, esophageal perforation. 3 questions will be definitely there in esophagus. In pancreas, there will be always question on pancreatitis and pancreatic necrosis. Pancreatitis and pancreatic necrosis, there will be always questions in Shackelford. It is very good. Please go through Shackelford. You will definitely get a lot of extra points than others. And pancreatic neuroendocrine tumor, cystic neoplasm, both are asked in the exam. More commonly asked than pancreatic carcinomas. Okay. So there are so many points. I have taken all the points from Shackelford. So whatever I explained here is BCD followed by ward, followed by minimally invasive, followed by open Beagers. So actually this topic is very beautifully explained in crispy manner in Sabiston. But you see Shackelford, it explains for many pages about this topic. So explaining lot of points, but everything explains about Panther trial. They explain about tension trial, which compared endoscopic and surgical step-up approach. So like that, many trials are explained in Shackelford for your completion sake. Okay. So these are the questions. Around 18 questions came from esophagus and stomach. And there are some questions which I could not get proper recalls, but therefore I'm putting them as such from hernia and bariatric. So 20-year-old male with a periumbilical pain with the bilious vomiting, CT scan was given. Actually, they told there is a CT scan given. So with the CT scan image was there with the showing the crowding of bowel loops like this on the right side with the dilated bowel on the left side. This is probably a right side paraduodenal hernia. because that is what can present to you in 20 years. I didn't have the image from this question, but people told this is probably a right side paraduodenal hernia. So idiopathic hypertrophic pyloric stenosis, gastric volvulus can be clearly ruled out. Midgust volvulus, these are all acute cases, childhood. But 20 years male will usually present to you with the right side paraduodenal hernia. So please go through that. It may be an option of hernia chapter question. And there is a question on who did first TEP. In 1993, Richard McKernan and William Law formally introduced the totally extraperitoneal technique. Richard McKernan and William Law. This is again, there was a question. Probably it may also be a general surgery question. And triangle of doom image was asked. I heard explaining that there is a this is a triangle of doom. This is a deep ring. Please understand, this is testicular artery, testicular vein going inside, and this is a vas deferens, and this is a reflected peritoneum. This is vas, gonadal vessels, reflected peritoneum. This is triangle of doom. Inside you have external iliac artery, external iliac vein are seen inside the triangle. So this is a triangle. So probably they asked the triangle of doom image and they asked you what is it. Temporary abdominal closure using Bagota bag, or opside sheath is done for trauma, damage control surgery. Also, we will put a temporary opside sheath, abdominal hypertension. So enterocutaneous fistula, we will not put any sheath because we cannot seal the fistula with a Bagota bag or opside sheath. The content, the secretion should come out and it should not fall on the skin. We will make a controlled drainage. That's all. Like we can even do a controlled drainage, but we will not do complete closure of the temporary closure and all. We will not do an EC fistula. Okay. Super obesity is BMI above 50. So obesity, morbid obese is 40. Above BMI above 40. Super obese is more than 50. Super obese is there. Super obese is more than 60. There are 3 types of obesity. So these are all, I think, the general surgery questions because they are not much focused in Shackelford and all. See, I'll tell you, in SG exams, surgical gastroenterology, INI SS surgical gastro is the easiest exam compared to other exams. Let it be cardiothoracic or vascular or plastic. The reason is very simple. You all prepare for NEET SS only one book, that is Sabiston. We always say one book is enough to crack NEET SS, means it is only Sabiston. So in INI SS, the SG, the one book which is enough to crack is in Sabiston 500 pages of SG and HPP. I'll say you, if you are going to be strong in this Sabiston 500 pages of surgical gastro and HPP, see, you have answered the double layer closure directly from Sabiston, and I am searching for that in Shackelford, multi-layer technique. So Sabiston is a perfect notes of 500 pages, is nothing but the notes of 2500 pages of Shackelford. So if you are having difficulty in reading Shackelford, you can always go with Sabiston. With only 500 pages of Sabiston, last year I took an interview from all the toppers, rank 1, rank 2, rank 3. All of them told, sir, I read only Sabiston. I have not seen Shackelford. This is what they told. This is I was actually wondering to hear this line from the students because 5-6 years back, nobody can crack an exam without reading a Shackelford. That much questions will be very tougher. And in fact, they used to read also Bloomgard in those days. Now I don't think there are much questions from Bloomgard. If at all there are questions only from Shackelford, so please be thorough with Shackelford if you have time, or at least 500 pages of Sabiston surgical gastro part, line by line you should read. Okay, this is the point I want you to tell. So I think we have covered all the surgical gastroenterology recalls. So I request you all, please go through the 4 videos. We have covered four faculties. Dr. Bharat has covered stomach and small bowel chapter 3 days back. 2 days back, Dr. Arun has covered colorectal anus, and Dr. Santosh Anand sir covered yesterday, and I have covered today. 4 videos we have now in this channel. Please go through these videos. And for previous year, October 2024 or May 2024 and all those videos, surgical gastropod is available in our app. In DocTutorials app, we have those videos. You can please go through those videos. Okay. So thank you all. So see you all the best for your exams. Do well.